So good evening. I'm so excited to continue our conversation on men's health in the United States. Tonight, we're focusing on Black men and health disparities observed among them in relation to their physical health. Did you know that President Clinton and the United States Senate passed a joint resolution in 1994 declaring a National Men's Health Week, and June is Men's Health Month? So as we head into this week's presentation, let's shed some light on the state of Black men's health in America. I am your presenter this evening. I'm Dr. Georgiana Logan. I'm an assistant professor and research associate, and I'm also the founder and executive director of the Men's Health Equity Institute. And so I'm excited to bring forth this presentation to really shed again some light on men's health, specifically African-American men, because it's a topic that really needs a little bit more further discussion. And so hopefully by the end of this presentation, I hope you'll be able to walk away learning a few different things that you may or may not have known before tonight's discussion. I hope you'll be able to discuss health outcomes for Black men in the United States. I also hope that you'll be able to identify factors related to premature death for Black men. I also hope that you'll be able to recommend strategies and solutions to address health disparities among Black men as we continue tonight's conversation. So, two terms that you'll frequently hear me mention are health disparities and social determinants of health. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, their socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So health disparities are a result of social determinants of health, which are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. These social conditions, these social, economic, and physical conditions in various environments and settings, so a school, a church, a workplace, or a neighborhood, that often lead to poor health is frequently described by the phrase place matters. As a result, these conditions lead to premature death rates or diminished quality and quantity of life, meaning you die before you're expected to, and you die with some or as a result of some problems with your health. That's why we focus on intergenerational. That's why the focus of intergenerational health is so important as we begin to shift our dialogue to health-related practices, beliefs, and messages transferred between family members of different generations that influence health and well-being. So there are several factors that can impact someone's life expectancy or rates of premature death that we see. And those social determinants of health have a major impact on people's health, well-being, and quality of life. And so the examples of these include safe housing, transportation, neighborhoods, racism, discrimination, and violence, education, job opportunities, and income. If you have access to nutritious foods and physical activity opportunities, do you live somewhere where there's polluted air and water, your language and literacy skills? And so social determinants of health, again, those conditions in the environments where people are born, live, learn, work, play, worship, and age, those different things affect a wide range of health functioning and quality of life outcomes and risks. So let's look at this a little bit further. So these 5 domains of social determinants of health encompass economic stability, education, social and the community context, health and healthcare, and neighborhood and built environment. So if you look at some of the subsets of these, your economic stability, we're talking about, do you have employment? And if you're unemployed, do you have access to even be able to go out and get a job, right? Or are you underemployed? So you work enough hours, but not enough to really thrive in society. Do you have do you have problems with food insecurity, right? So if you're unemployed, you might run into some areas there. And then if you live in certain neighborhoods, there also may not be opportunities for fresh fruits and vegetables, depending on if there's grocery stores or marketplaces in the area. We also look at your housing instability and rates of poverty. And then when you get to education, we look at things such as, do you have access to early childhood education and development? Are you enrolled in higher education? So do you have an opportunity to go to college? Did you even graduate from high school? And then what are your language and literacy skills like? When we talk about the social and community context, we're talking about things such as like civic participation. And that's, do you have a voice or a seat at the table in public policy decision making, right? What's going on in your communities, what's going on in your state, what's going on in the government that really can hinder or help you in this world. We're also talking about discrimination, incarceration, and social cohesion, which just is your networking abilities with other people in the community. We also look at health and healthcare. So do you have access to healthcare? Do you have access to primary care, let alone specialty care? And then what is your relationship with health literacy with those providers? We also look at the neighborhood and built environment. So do you have access to foods that support healthy eating patterns, right? So those fresh fruits and vegetables that kind of help curtail rates of obesity or help with managing chronic health conditions such as hypertension and diabetes. Do you live in a neighborhood where there are lots of crime and violence? What about the environmental conditions, right? Is the soil toxic? Is the water toxic? Is there air pollution? Are there mold in the homes that leads into quality of housing? So all of those key domains are part of social determinants of health. And when we consider those determinants and their impact on health disparities, we have to dig deep and look at the root causes of health, because health is shaped by more than individual choices. And I know you like, Dr. Logan, what do you mean? What I mean by that is I want to give you a graphical representation. So I picked this picture because it's deep and it's saying a lot, right? We turn a blind eye to a lot of stuff in society, and we don't always speak up and speak out when necessary. And so health inequities really come from the unequal allocation of power and resources, called the determinants of health, in which we just discussed. And then there also are root cause because of structural inequities, the distribution of power and resources differentially across lines of race, gender, class, sexual orientation, gendered expression, and other dimensions of individual and group identity. And so when you think about health disparities in terms of overall health, let's look at this concept a bit further. So when we talk about health disparities, we're talking about differences in the incidence, prevalence, morbidity, mortality, burden of disease, and other adverse health condition and outcomes among specific population groups. What I mean by that is when I say incidence, we're talking about the number of new individuals who develop a specific disease or a specific health condition over a particular time period. So how many African-American men or Black men will develop hypertension or diabetes between 2021 and 2024? When we talk about prevalence, it's a measure of all individuals affected by disease at a particular time period. So how many African-American men or Black men have hypertension or diabetes in 2021? When we look at morbidity, it's just a condition of being ill, diseased, or unhealthy, right? So do you have hypertension? Do you have diabetes? Do you have cancer? And then when we talk about comorbidity, that's having more than one disease or condition at a time. So do you have hypertension and diabetes? Do you have hypertension, diabetes, and cancer? What combination of diseases have you been diagnosed with? And all of that contributes to mortality. And mortality is just your risk of death. So we look at the number of deaths in a population in a given time period, right? So how many people died between 2021 and 2024? And then when we start looking at morbidity and tacking on other factors, what's someone's risk of dying within that time frame because of these conditions that they have? And so when we talk about health disparities, specifically among African-American men, we look at things such as like intergenerational stress and epigenetics. And what I mean by that is experiences of the father passed down from offspring, right? We're just looking at what did daddy pass on to a daughter? What did he pass on to a son? Because we know that intergenerational stress experienced from discrimination and racism, being a Black man in America, and the trauma many may experience has an effect on their offspring. When we talk about life expectancy or premature death, we know that Black men die at 2 to 3 times the rate of whites from chronic diseases that are preventable and treatable. And when we talk about healthcare and compliance, distrust can lead to a failure to go to the doctors, meaning we're catching conditions when they're out of control, making them harder to treat, and then having providers that look like you, either Black male doctors and physicians, and also tackling things such as masculinity, right? Some medical tests make men uncomfortable for various reasons, but we need you to go to the doctor. We need you to go get checked. And so let's expand on this topic of premature death. Communities of color bear a disproportionate burden of ill health in the United States, with little improvement in overall mortality differentials during the past 40 years. Black males continue to fare worse than Black women and white Americans in life expectancy, age and cause-specific morbidity and mortality, insurance coverage, and access to adequate health care. So Black men continue to have substantially lower life expectancy at birth than Black women, white men, and white women. And so we know that Black men have the highest overall death rate from cardiovascular disease. Equally as concerning is the fact that deaths occur much earlier in African Americans than whites. And so when we look at life expectancy in the United States, on average, men are expected to live 76 years and women are expected to live 81 years. So that's a 5-year difference, right? And you can look at this trend from 1955 up into present, 2020, which the latest data came out. And so when you look at life expectancy for men in the United States, white men are living to be approximately 77 years of age, while Black males are only living to be 72 years of age. And then when you compare that to females, white females are living 81 years, at least 81 years of age in most cases, and Black females live on average 78 years of life. And so when you start to look at these numbers, that means that white men are living 5 years longer than Black males, and then Black males are living 8 years less, like 9 years less than white females, and 6 years less than Black females. And so we have a problem, right? We got to talk about this. So let's look at some facts. We can predict the quantity and quality of life for most states in the United States. So the Robert Wood Johnson Foundation have what is known as the county health rankings, where they tell you if you live in Michigan, California, Alabama, etc., and reside in Genesee, Alameda, or Tuscaloosa County, we can predict on average life expectancy for those areas and assess overall quality of life for those areas as well. And so when we talk about quantity of life, we're talking about premature death, right? And then when we look at quality of life, we're talking about your satisfaction with life. How happy are you with your physical and mental health? And we look at a variety of indicators to assess that. So quantity of life is the total amount of years you live, while quality of life concerns how well you live those years. And so I like this quote. It's by an author who's unknown. And it basically says that man's greatest problem is not to add years to his life, so your quantitative existence, but life to his years, so your qualitative existence, right? We want you to live a well, happy, productive life, no matter how many years it is that you live. And so we can predict a lot by looking at contributors to poor health by state, county, and zip codes. I referred to you already about Place Matters, based on health records and data that we obtain from communities. In regards to health disparities, 4 main contributors are associated with poor health outcomes, which are obesity, your diet, your participation in physical activity, and your physical exams. Are you going to the doctors or not? Are we catching things when they're happening? Are we waiting till they're out of whack and then try to do something about it? So when you add these with the social and environmental risks, we get into trouble, and those premature death rates that we talked about skyrocket, especially for Black men. And so let's go a step further. So when we look at the severity of obesity for minorities in general, because I think you need to see it to understand the magnitude of the problem, right? So we talked a lot about diet and physical activity on last week, so I won't repeat that. But I want you to consider is when you look at this map, you'll see in the dark red coloring that 35% of African-American adults are considered obese among these states. Look at them. 31 states and the District of Columbia have 35% or more Blacks classified as obese. There are only 2 locations on this map where minorities are not considered obese. Almost 40% of Blacks in the US are considered obese, the highest prevalence among all racial and ethnic groups, and 37.5% of Black men in the US are considered obese. And get this, 56.1% of Black women in the US are considered obese. And so Black women have the highest rate of obesity or being overweight compared to other groups in the United States, because about 4 or 5 Black women are overweight or obese. And although this may be true, African-American men have some of the poorest health outcome in comparison to these African-American women. And so what does that mean for the implication for health? So we know that hypertension and diabetes pose a risk for health in many ways. Let's just state the facts. And so, despite a reduction in disparities reported for death rate among Blacks and white over the years, disparities in the leading causes of death, which are your heart disease, diabetes, for Blacks compared with whites, remain higher and persistent across the lifespan. Blacks are more likely to be obese and less likely to have a normal body weight in all age groups compared with whites, and Blacks are less likely to participate in physical activity for the recommended amounts as set by national guidelines. We know that Blacks with high blood pressure are more likely than whites to report not taking their medications correctly to control it. And that's problematic because Blacks have a higher burden of myocardial infarction or heart attacks, heart failure, stroke, and other cardiovascular events. Hypertension is the key risk factor for these events. So Blacks have the highest incidence of stroke among the groups in the US, and their strokes tend to be more severe and the outcomes are far worse. And so when we start to look at this for Black men, the results are cringeworthy. I'm telling you, we have a problem. And so when we look at hypertension of Black men specifically, it matters because hypertension is the leading cause of preventable disease and death in the United States. Black men are more likely to die of serious chronic illness than are white women. So for example, 40% of Black men with heart disease die prematurely, nearly double the rate of white men. Hypertension is particularly salient for African-American men as they are 1.5 times more likely to be hypertensive than white men. 35% of African-American males ages 20 to 74 have hypertension compared with 25% of all other men. Disparities in hypertension control among African Americans are a primary source of disparities in cardiovascular diseases and related events. So therefore, Black men have the greatest burden of premature death, dying early, and disability from hypertension in the United States. So when you look at what's killing Black men and women, it is diseases that are preventable or treatable with great survivability. When you even break this down into diabetes specifically, we know that Black adults are 60% more likely than white adults to be diagnosed with diabetes. Blacks are twice as likely than whites to die from diabetes, and Blacks are 3.2 times more likely to be diagnosed with end-stage renal disease as compared to whites. So that means your kidneys are failing. And then Blacks are 2 to 3 times more likely to be hospitalized for lower limb amputations as compared to whites, right? So your diabetes get out of control, and you may end up with like cutting off a toe, sometimes a foot, sometimes even up to your knee, depending on the risk factors or the conditions that you have. Risk factors for diabetes are obesity, hypertension, high cholesterol, and smoking. And so what I want you to know is that type 2 diabetes has increased 160% fold for African-American males in the United States over the decades. Black men ages 18 and older are 1.5 times more likely to have diabetes than white men. And although Black women are more likely to have diabetes, Black men are more likely to go undiagnosed, unmanaged, and experience poor health outcomes as a result. Black men who have diabetes are 2 to 3 times more likely to develop one or more serious complications associated with disease, including those amputations, kidney failure, blindness, and cardiovascular disease. Diabetes is specifically problematic for men because it often leads to erectile dysfunction, or having an overactive bladder, male incontinence, the increase in urinary tract infections, and retrograde ejaculations. And so hypertension and diabetes disparities are not new. So what happens when we have a person who has high blood pressure and diabetes co-concurrently, and how does that affect health? We could throw in cancer into tonight's discussion as well, but we'll save that for later as it's a beast to tackle by itself and warrants its own presentation. So when you talk about somebody that have hypertension and diabetes together, it means they have a comorbidity, meaning they have more than one disease or condition at the same time. And comorbidity disease example, so I said you can have diabetes and hypertension. You can have diabetes and cardiovascular disease, or hypertension and cardiovascular disease. You can have diabetes, hypertension, cardiovascular disease, and asthma. The combination is on, right? What I want you to know is that there are potential complications as a result of having comorbidities. They increase your risk for mortality, so meaning they increase your risk for dying earlier. They diminish your quality of life because if you have diabetes, hypertension, and cancer, they require you to go to multiple doctor's appointments. You're probably taking multiple medications. You may be missing out on work, missing out on time with your family, a lot of different things. These multiple comorbidities can have treatment complications. They also increase healthcare utilization, and they definitely raise your healthcare costs. Diabetes is a particularly nasty disease, and the healthcare costs associated with that are extremely, extremely high for just a month's worth of medication. So let's go a step further. So since we're talking about African-American men, what does that look like for minority children and their adolescent health, right? So the case for young Black men. And so when you look at minority children specifically and adolescent health, when diseases start early, they can lead to death earlier. And what we know is that cardiovascular disease, or CVD, is the leading cause of death in the United States. It often begins in youth, and the early stages of its development are related to known risk factors, including hypertension and obesity. So we keep going back to these two things, right? 46% of African Americans ages 19 or older suffer from cardiovascular disease. Black children ages 2 to 19 years old are 2 times more likely to be overweight or obese than white children. Black children are also almost 3 times more likely to not consume the recommended servings of fruits and vegetables than white children. Black boys and girls have higher BP levels and a higher prevalence of hypertension than whites, right? The facts are there. Blacks in age groups 13 to 84 and 35 to 49, when you break them down, are twice as likely to die from chronic health conditions, so having heart disease, stroke, and diabetes, than whites in the same age group. So I'm hoping you see that this is a lifespan problem, right? This is an issue across the board. And then Blacks age 18 to 34 years are less likely to have a personal doctor or healthcare provider than whites in the same age group. And so in relation to Black men's health over the lifespan, we know that African Americans bear a disproportionate burden of risk factors, incidence, morbidity, and mortality rates associated with those chronic diseases that we see. And so we have to start looking at intergenerational health. And what I mean is that lifestyle factors are likely to affect human health and offspring via epigenetic mechanisms. Kind of touched on that in the beginning. What I'm saying is that their variations in gene expressions are influenced by epigenetic factors, so our life experiences and our habits, including our nutrition, behavior, and environmental toxin exposure. So epigenetics has the potential to change or come out in subsequent generations or be transgenerational. And what I'm saying is that our traits, behaviors, illnesses, and good and bad experiences leave these epigenetic footprints. However, they may be removed through lifestyle changes and environmental modifications. And so the Men's Health Equity Institute focuses on several key programs. One program that we have is Black Men Move. It's an intergenerational physical activity program to reduce obesity and risk for chronic health conditions by promoting active lifestyles among African-American men to address hypertension and health disparities. So we focus on healthy eating, physical activity, medication, and appointment compliance. This specific program will be the first that we know of that's gender specific, that is an intergenerational program in efforts to reduce hypertension and diabetes health disparities among African-American men and African-American adolescent males. We understand that any successful male health advocacy initiative should use an evidence-based approach, which takes into consideration social, cultural, and economic factors, right? So it also has to be gender specific, and those barriers to access in healthcare and creating new ways of engaging men should be one of the first goals of any initiative. And that's what we try to look at the Men's Health Equity Institute. And so what do we understand about intergenerational learning and intergenerational practices, and then how do they help influence behavior? Because intergenerational learning is a transformative and informal process that takes place through natural multi-generational interactions. It's a cultural exchange of knowledge, customs, beliefs, and practices between generations through a co-learning process. And so basically, intergenerational practice refers to the activities that bring together older adults, young adults, or children. And so in these intergenerational practices, it's inclusive and builds on the positive resources that each generation have to offer each other and the communities in which they reside. Another important topic that we consider when designing our programs is culture. And culture is defined as the set of distinct spiritual, material, intellectual, and emotional features of a society or a social group, which encompasses, in addition to art and literature, lifestyle, ways of living together, value systems, traditions, and beliefs. So culture is not limited to one criterion. It's composed of overt beliefs and practices, as well as the subtle and taken for granted conventions that frame our sense of reality, define what is normal and abnormal, and give our lives a sense of direction and purpose. And so we take culture into consideration because we know it influences health in a number of ways, right? So how might culture influence health? Well, when you think about nutrition, right? When you think about your palate, your taste preferences, that can be, when we're talking about creating programs for African Americans or African American men in general, we have to take that into consideration because again, you look back at culture and traditions, we have been raised on different tastes, preferences and things of that nature. So we have to talk about that. Physical activity. Men are often seen as the breadwinner in families, right? And if they're working long hours and barely at home, and then when they do get off work, they're tired, how do you find time for them to include any kind of physical activity into their lifestyle? So we look at things of that nature. Body image. African Americans are sometimes or tend to underestimate their body size sometimes, right? And sometimes 20 to 30 extra pounds on us can be considered ideal and that nothing is wrong or that you're not considered overweight or obese. And so we have to talk about that. Gender and sexual orientation, culture implications to consider. Again, we're talking about patient provider communication. Those are things that you have to understand, which lead us into patient provider interactions and communications. Also to adherence, right? How do we get men to actually come to their yearly checkup visits and appointments, right? How do we get you to adhere to medication? Because we know that African American men, sometimes when you put them on hypertension medications, it can make them flaccid or make them have problems with getting an erection. And so some men just don't like taking medication for that reason. So we have to talk about those things. Your religious beliefs. What about complementary and alternative medicines? Especially if you think about like the Deep South or sometimes even up in the North and other various regions, sometimes we do things like apple cider vinegar, garlic, and are those things safe with what we're trying to get you to do to kind of change your life and your health around, right? So we got to know what else do you do in terms of traditional and non-traditional medication to really try to improve your health and well-being. And then mistrust, that's huge, right? We know all the stories about medical mishaps and things that have happened throughout history, such as the Tuskegee Airmen event, which most people refer back to, but there's tons and tons of medical things that have happened historically that lead to mistrust in our medical system, specifically among minorities. You have to think about that. And what else can you think of? I don't know. The list goes on and on. And so we encourage you to check out our programs. Visit us at www.menshealthequityinstitute.org. Follow us on Facebook or Instagram and YouTube at Men's Health Equity Institute. You can also look up our Twitter page, which is Equity Men's. We also have a TikTok, right? That's a new age thing. And look up Men's Health Equity, where we're posting content constantly, trying to raise awareness about men's health, and tonight specifically African American men's health. So my final remarks is that we thank you for constantly participating in our discussion and our events every single week for the month of June. We're trying to bring you great content since it's Men's Health Month that's focusing on all things men's health. And so we don't want you to forget about our scholarship opportunity that we have, where we're giving away 3 $500 scholarships to recent high school graduates or men currently enrolled in a 2 or 4 year college university. You just have to submit one academic or professional reference and complete the required application to be considered. You can reside in, you must reside in the US, and you can have any academic major. Applications are due by June 30th to our email address below. We also want to remind you that we are a nonprofit, and so we thrive off donations. And so if you would like to support us by donating to our cause, you can again visit us at www.menshealthequityinstitute.org. Our donations go through PayPal. We also have a Tiltify account, which is Men's Health Equity Institute. You can go to tiltify.com and search for Men's Health Equity Institute and donate that way. or you can email us for a sponsorship form, and you'll be able to see all the different levels of sponsorships and types in which you can contribute to our organization. As far as our upcoming events, next Thursday on June 24th, we have a presentation on HIV awareness because June 27th is National HIV Testing Day. And so we really want to highlight what's going on with men's health in relation to HIV and encourage you to go out and get tested on June 27th and know your status. It's very, very important. And then again, on Wednesday, June 30th, scholarship applications are due. That's the deadline. And so if you want to contact us, you have our P.O. box information, our phone number. Again, feel free to email us at any time. We really thank you for joining our discussion on this evening. We hope that you've learned something from our presentation, and we look forward to you joining us next week as we continue to talk about men's health, specifically as it relates to HIV and HIV awareness among men. Thank you and have a good evening.